left hypochondrium and pelvis. This must be associated by rapid history, ample history, A, allergies, B, M, medications, P, past illness or pregnancy, L, environment relating to injury. Then we will go to secondary survey, rapid and complete history and physical examination of the to preserve changes in clinical findings are often the key to correct the diagnosis. There is patterns of injury as associated with others, like pelvic fracture associated with bladder injury and urethral injury. Then both management plan according to priorities. Thank you.
شكرا دكتور عبد الرحمن. وبرضه بعد اذن حضرتك هنخلي الاسئله كده اي حد يكتب. اتفضل دكتور عبد الحميد.
0.5 to 1.5% of all rhabdomyolysis died due to trauma cases. Penetrating trauma is the vast majority, usually firearms and abdominal gunshot wounds. Colon is the second most common after small bowel injuries. In anterior abdominal stab wounds, most commonly injured organ in patient undergoing laparotomy. Transverse colon is the most commonly injured segment after gunshot wounds. Left colon is the most commonly injured segment after stab wound. Iatrogenic injuries, especially after endoscopy for bulbectomy or deeper biopsy, and surgical operation, especially in obstetric and gynecological operation, and certain neurosurgical operation. Low velocity civilian penetrating wounds or stab wounds usually cause limited damage, and most of them are amenable to debridement and primary repair. In high velocity penetrating injuries, such as war-related common, 10.6% of patients undergoing laparotomy. Traffic trauma is the most common cause. Left colon is the most commonly, followed by right colon and transverse colon. From American Civilian War up to American Iraqi War, mortality from colorectal injury had decreased from 90 to less than 10 or 8%. Advanced trauma life diagnosis, the advanced trauma life support, primary survey, history taking, physical, thorough physical examination, including abdominal examination to evaluate sites of penetrating wound, blood per rectum in case of distal colon and rectal injuries. Rigid proctoscopy should be done by senior physicians who are accustomed to see perforation and determine its level. Triple contrast CT is the gold standard with sensitivity 90% and specificity 96%. Diagnosis usually follow suspect and luminal extravasation. Ultrasound, diagnostic peritoneal lavage, and laparoscopy have little or no role in the evaluation of suspected cases of colonic injury. In some cases, diagnosis may be delayed by many days with catastrophic consequences. Diagnosis of colonic injury usually done intraoperatively. Grading of colonic injury. From grade 1 to grade 5, we classify grade injury into destructive and non-destructive grade in chronic injury. Non-destructive injuries include grade 1 and grade 2. Grade 2, lacerations less than 50% of circumference, and grade 3, which is destructive chronic injury, involve lacerations more than 50% of circumference. Grade 4, transection of the colon. Grade 5, transection of the colon with segmental tissue loss. And blunt colonic injury, massive deceleration force associated with blunt mechanism makes the colon more susceptible to ischemia from mesenteric compromise. Therefore, traditional management schemes for penetrating chronic injury may not apply to blunt injuries, putting the patient at high risk for suture line failure. Indicators of destructive blunt chronic injury. Any serosal tear, more than 50% chronic injury is a destructive chronic injury. Any full thickness perforation, whatever the size, is a destructive chronic injury. And mesenteric devascularization is a destructive chronic injury. Operative management. There is now enough class 1 evidence supporting primary repair in all non-destructive chronic injuries irrespective of its risk factors. In case of destructive chronic injury, we categorize the patients into destructive chronic injury with risk factor and without risk factors. With risk factor, the intervention should always be done. Without risk factors, primary repair and anastomosis. The risk factors include patient with comorbidities, patient with shock, patient multiple blood transfusion, more than 6 packed red blood cells for stabilization of the patient, any patient with peritonitis or associated injuries, or delay in diagnosis more than 6 hours, or major spillage of more than 5 centimeters around the wound. As regard the colonic wound location, the determinant factor for colon-related morbidity, either social line failure or abscess, or colon-related mortality, is extended right hemicolectomy. In case of cecal perforation, you can do end ileostomy with long Hartmann closure. Double barrel colostomy, always done in mobile parts of the colon, either transverse colon or sigmoid colon. Externalization of repair the injured segment should not be done because there is a high incidence of leak, more than 50% after replacement of the injured repaired colon. Resection with endocolostomy and the mucus fistula or Hartmann procedures done on the left side. Primary closure of laceration with proximal fecal diversion by ileostomy or colostomy when the proximal part is mobile and distal part of limited mobility. In descending colon distal injuries. Extent of colonic injury must be adequately assessed by adequate mobilization proximal and distal and the retroperitoneal part of the injured colon. Ureter must always be identified and examined in cases of ascending or descending colonic injuries. Intraoperative, when find the barrel and on top of blunt colonic injuries, it is only explored when there is high index of suspicion or if there is CD evidence that there is underlying colonic perforation. Failure to adhere to this important surgical principle is serious error with medical and legal implications. Resection margin must be well perfused with versatile blood flow, and resection and the anastomosis should be tension-free. Either method of anastomosis, hands-on or stable, statistically there is no significant difference in colon trauma series as regard anastomotic leaks. Also, 1 layer or 2 layer according to surgeon preference. Subgroup of patient with multiply injured patient with documented hypothermia, coagulopathy, and acidosis. They need damage control surgery, priority for control of bleeding, and then massive transection with GI stapler. And then patient is transferred to ICU for 24 to 72 hours. And after then, we can choose delayed primary repair or stoma. Rectal injuries. Level of the rectum, either intraperitoneal, applies the same principles as colonic injury. Extraperitoneal part, either proximal or distal, and the perineal part of the rectum. Penetrating trauma is the vast majority. Blunt trauma from 5 to 10. Examination, abdomen and pelvis, perineum, and the genitals should be examined. Digital rectal examination show gross blood, show sphincter tone, show foreign body. Sigmoidoscopy together with digital rectal examination have a diagnostic accuracy of 80 to 95%. In a stable patient, we can do X-ray, cystoscopy to see extravasation in case of rupture of urethra or bladder, CT. On the right side, this picture on the right side, there is a dye in the rectum, and this injury of the rectum to the dye reach the bladder. On the left side, is here fracture pelvis, pubic ramus, and this free intraperitoneal fluid, and the second wall of the rectum. Management of extraperitoneal rectal injuries. All the classic 3D have been challenged in the modern rectal injuries, diversion, pre-sacral drainage, and distal rectal washout. In selected cases of small perforation and intraperitoneal colonic injury, intraperitoneal rectal injury, primary repair without proximal fecal diversion. Hartmann procedures should be reserved for patients with extensive destruction of the rectum, even abdominal perineal resection in case of destruction of anorectum. Proximal diverting loop colostomy alone without suturing perforation in mid-rectal injury, which is usually inaccessible, especially in male patients with narrow pelvis. Pre-sacral drainage not done in case of Wounds is the anterior part of the distal rectum, or extraperitoneal wounds that are explored and repaired effectively, massive extraperitoneal lesions with stoma. It can be done by posterior wounds, posterior extraperitoneal rectal wounds, large sacral injuries, a lot of spillage. It's usually done by for short time, 3 to 4 days. Distal rectal washout is no evidence that it reduces morbidity. These plaques should be abundant. Patient position, usually isotomy to enable sigmoidoscopy, but if the patient is hemodynamic or unstable, exploration to stop bleeding is a priority. After repair of the rectum and any genitourinary injuries, to separate the repairs with wheel vascular tissue like omentum to reduce the risk of rectovaginal or rectovesical or rectourethral fistula or vascular graft infection. Ostomy, usually loop colostomy, easy to close, usually after 6 to 8 weeks. Antibiotics, preoperative antibiotic is mandatory against enteric, aerobic, and anaerobic, including Bacteroides fragilis. The duration of antibiotic prophylaxis is usually 24 hours. Place of laparoscopy in extraperitoneal rectal injuries. When we confronted with injured patient without any signs of acute abdomen and there is bleeding per rectum, and we perform a sigmoidoscopy, we find there is a perforation and determine its level, and have excluded bladder injury by CT cystography, we can do laparoscopy. If during laparoscopy we find intraperitoneal blood or breaches of peritoneum, convert to laparotomy. If it is normal, no suture repair, no presacral drainage, no distal rectal washout, only sigmoid colostomy. Thank you.
شكرا دكتور عبد الحميد على المحاضرة القيمة. Next talk